Good morning, everyone. Hi, everyone here live from the Leon Conference Room at Rhode Island Hospital. Can everyone on Zoom hear us? You can type in the chat.
Yes, we can.
Okay, great. Thank you. So, and welcome also to everyone on Zoom. We have some folks tuning in at nighttime from the Philippines, and we also have people from elsewhere too. So without further ado, I'll be presenting a series of cases and reflections from my time spent at Philippines General Hospital. And I wanted to thank the NREF Sanjeev Bhatia Honor Your Mentor Fund for graciously funding this experience, and the AANS CNS Pediatric section for making this opportunity possible, including Dr. Heather Spader, who many of us here know and love, and everyone who contributed to that fund and made this possible for me to go. And of course, thank you so much, maraming salamat po, to PGH Neurosurgery and my gracious hosts and mentors, all of the residents, Sir Gap Legaspi, Sir Ronnie Baticulan. Just a little bit of introduction. Sir Ron is it was my main mentor there. He's a pediatric neurosurgeon who trained at PGH and did fellowship in Australia, and also spent some time also training in Uganda as well. And I learned so much from him. And there I am holding his book, which he signed for me, and I highly recommend. Dr. Gap Legaspi is also on the call. He is the hospital director at PGH, and I think current or prior chairman as well. And he is coming to Boston in July, so you all over here might actually meet him in person. But not only learning neurosurgery, but also received copious amounts of Filipino hospitality from him, as we're pictured all here in his home, which he hosted us several times. So this rotation was an observership. Under supervision, I was able to participate in operative procedures, rounding, assessing patients, managing pediatric patients on the floor. And of course, it was also, all of the learning was much thanks to the AANS CNS Ped section faculty members, including, this is one of our Zoom calls that we had every Wednesday morning that I would discuss my cases. And Dr. Philip Aldana, who's been to PGH several times and founded the Neurosurgical Outreach Foundation, which goes there regularly, as well as Dr. Patricia Clerkin, who's the division director of PEDS in California and an affiliate of UCSF, Dr. Ariana Barkley, who is assistant professor of PEDS at University of New Mexico, and Dr. Petra Klinga, our very own, joined us for a few of these conferences as well, during, every Wednesday, during which we would discuss the cases in this fashion. So the aims of my time there were really to walk in the shoes of a resident in a lower middle income country, a place just different from my natural habitat. I wanted to see what it was like and learn more about pediatric neurosurgical disease management, especially pathologies that we don't see as much in our natural habitat here, like open dysraphism, congenital disorders, and also to identify any chances to collaborate or do research. My role was to be a learner, an observer, a co-resident, a trainee, also a friend, a helper, general enthusiast of everything. And I was also a guest and a visitor. I wasn't there to take cases from anybody. I was not there. It was not a medical mission. I was not there to save anyone or to convince anyone that my Brown neurosurgery ways of doing things were better than theirs. I was there to learn from the experts of their patients and their practice, coming from just a place of learning. And the Philippines, to give a little background, is a beautiful place. It's a lower middle income country by World Bank classification 2022. It's in Southeast Asia, and it is an archipelago in geography with thousands and thousands of islands and 81 provinces. And Sir Ron actually did this study recently looking at the neurosurgical workforce there. There are 174 neurosurgeons in the entire country. 68 of those practice in the National Capital Region, including Manila, where I was. And out of 90,000 essential neurosurgical procedures there every year, 70,000 of them are unmet. And compare that to our natural habitat here in the US and New England, we have 5 neurosurgeons per 100,000 here in Rhode Island. And there are only 0.5 per 100,000 in the capital there. And also to give you more context, the population pyramid is quite different. It tends to be more younger folks and children compared to our situation here. And so, a great place for anyone who wants to learn more about the care of children. The healthcare system is also quite different. It's bifurcated into public and private, the public healthcare facilities being the places that people who cannot don't have money to pay for their care go, and private places being entirely fee for service. And PGH is one of those public institutions, and it serves the large amount of people in the Philippines who are living under the poverty line. And so we saw a lot of advanced disease because of this, and also because of the just general catastrophic financial expenditure that tends to happen in this population. This is an interesting paper that I found, but it's, a lot of people don't seek treatment at all for a while in the beginning. And so you'll see that we saw a lot of massive tumors, late stages of disease. So Philippine General Hospital is the is a tertiary referral hospital. It's a world-class institution, the neurosurgery department. It attracts the likes of Mitch Berger, who visits there, I'm told, every year or so. And they're also doing, they're leaders in the field of diseases like XDP, and we'll talk a little bit about their clinical trial. It is state-owned university run by the largest university in the Philippines. It's a tertiary referral center, the only tertiary referral center for charity neurosurgical patients in the country. And so, everything eventually will come there. And also, if I am misrepresenting any of these facts, anyone from PGH can kind of reply in the chat there and let me know. But the charity service has 1,000 beds, and they also have 500 beds devoted to the pay service. So the pay service is not super different from our natural habitat here at Brown, but except for that the patients pay on a fee-for-service basis for every single service, every single supply. The charity service, on the other hand, point of care is free, but if you need implants, screws, rods, shunts, etc., you will have to pay for it, or usually is the case that your resident will have to do a lot of paperwork to request foundation funding. The residents are the primary surgeons and doctors there, and they manage the patients and operate after discussions with their consultants, which is their term for attendings. The resources are a little bit different between the charity and pay services. In the charity service, you're in a big room with 50 beds and no AC in the tropical climate, which is always 80 degrees, and I was always sweating, as opposed to your private room and more availability of certain things on the pay service. So I was on the charity service with the neurosurgery residents. The training is a little different too. The first year is like a general surgery buddy consult year. You're also kind of a jack of all trades. You do things in the OR, like you shave and prep the patients and position, and sometimes you'll assist, but you're generally running around always in the OR, like here, Dr. Jimbo. Your first year, you're decked, meaning assigned all cases of hydrocephalus, dysraphism, trauma. Your next few years, you're assigned all the meningioma, simple brain tumors, endoscopy cases, and then following that, your chief years, complex brain tumors, aneurysms. You get 7 days of vacation per year, no formal weekends, although every other weekend you do get an 8-hour period during which you're not required to be in the hospital. And so, of course, they work really hard. They're super dedicated. And they even have to pay for a lot of their supplies on their own. There are general supplies as well, but residents who want to, every resident basically has their own drill, craniotome. If there are special instruments they want to use, they'll purchase them themselves, all micro instruments. And there are no hospitals there are no laptops or computers in the hospital for residents to use. So all patients, charting, DICOM review, et cetera, is all on their own devices. If they want loops, if they want headlamps, they'll have to buy that on their own, as well as their own scrubs, which everyone looks really good in, and everyone has their own name embroidered on their own scrubs. It's about 25% of one annual resident salary amount that they spend really buying all of this stuff that they need to be a neurosurgeon in training, that they then use, for the 6 years. And a lot of the instruments are actually bought on eBay, I found. So they're really dedicated. This is the workroom where I lived with them. We basically live there. And what does it look like to do a case? So if you'll see a patient in clinic, this is the OPD, which is basically a big room with a lot of desks. And once you're done seeing one patient, you say next, and then they'll send you another patient. Then if the patient's operative, you'll have to wait for an elective bed to open up. This could be, even up to a year. And then you'll call your patient, tell them to come in. You'll review your operative plan with your chief resident, and then you're attending or consultant. You'll book the case, you'll go to the operating room. If you'll need special instruments of your own, you'll have to go to the OR supply place and check them out. And if, of course, if you need implants, you'll have to request foundation donations, do a lot of paperwork, and wait for that to be funded. So here I am with some of my instruments that I brought, thanks to Tom Carlton, who helped me identify some extra things that I was able to bring and leave there. And I thought it was cute that some folks bring their instruments in little Muji cases like this. And so you'll put up your films on the negatoscope. A lot of the films are, patients will come a lot of times with physical films that you're planning off of for surgery. And there you go, you start your case. And don't forget, though, before every case, you'll need to put on a gauze sweatband, because it was rainy season when I was there. It was always 80 degrees, and you don't want to sweat into the operative field, especially after, rounding, when you look like this, like you've done Bikram yoga. The culture is also different. It's than in the US. It's very hierarchical. Everyone's called sir, ma'am. The honorifics are used. It's generally a little bit more quiet than us, maybe sometimes obnoxious Americans out here. People don't really speak out of turn, and they're very used to, they're very used to this, and this is kind of just the culture of the whole country. People round, as you see, in plain clothes, and then they have separate scrubs that they're only allowed to wear in the OR. The healthcare team was quite different. In addition to what we're used to, they also have a family member or a watcher required to be at bedside 24/7 in the charity hospital. And this person actually does a lot of like what CNAs would do here. And this is a text message chain between me and a patient's mom, who was his watcher, who is actually the one who's kind of alerting me to like EVD issues or recording the EVD output. And here's another watcher that we're telling that person to be an extra set of eyes to know and make sure if an EVD is clamped or open. The clinical caseload, it was quite a fire hose at times, it felt. When the first week that I arrived, this was all of the pending cases for the charity service on the board. Here we have 9 ruptured aneurysms, ACOM, PCOM, M1, PCOM, A2, ACOM, MCA. We had 11 very large adult tumors, 2 spinal fractures. Orthopedics does, I think, most of the spine there, but neurosurgery does do some as well. But you'll see that they have plenty of cranial to run around after. Pediatric tumors, we had 4 of them waiting in-house, and we had at that time 7 neonatal shunts who had their open myelomeningocele repaired the week before I arrived, and we're just waiting there to be shunted. We had 1 open myelo, day of life 4 waiting to be shunted, 3 other revisions and insertions. And so you look at this list, and I ask any one of you, which of these cases do you want to do today? Any of the 8 unsecured ruptured, post-bleed week 1 aneurysms, or do you want to do a neonatal shunt, or do you want to do this massive obstructive hydrocephalus 4th ventricular pediatric tumor? It's almost impossible to decide. And it was, it was hard, really hard. But do not fear, the neurosurgeons are here. As I mentioned, the neurosurgery residents are the primary surgeons for all of the charity cases, and they get 2 operating rooms a day, 24 hours a day to operate, to get these cases done. And this is a PACU on a busy day. As you can see, the stretchers are really just kind of lined up back to back. The work never stops. This was after a dinner at Sir Gap's house, during which Chief Diana is still staffing an operative case at 1 a.m. So everyone works really hard, but thankfully there's always really good food available for anyone who's brought their belly to Asia, and so, it was a great time. So now we'll get into some cases. I'll go by kind of pathology. I was able to participate in 7 dysraphisms. I'll highlight just 3 of them. This was a 2-year-old male who had delayed ambulation. He was born with this large complex mass, macrocephaly. He was only really cruising, standing with assistance. He was born with this, and he'd been waiting for surgery since birth, but because of long wait lists, the foundation was able to help him actually get a spot on the pay service at PGH with Sir Ron. And so here's the lesion, and you can see there's a lot of different tissue types. This almost looks like it's trying to be conjunctiva, maybe an eyebrow, some hair. And looking at the imaging here, we see a fibrous tract going into this thecal sac and like a large syrinx, and a lot of different kind of tissue types in there. A split 2 diastomatomyelia, split cord malformation with 2 hemicords and 1 dural sac and a anterior ventral septum. you can see, and then here's where we get into the two hemichords, and you can see that even in this tissue back in the lesion, there's almost like a second spine here, like few different like vertebrae, it looks like. And you see here also on the CT. So we were kind of calling this like almost on, it is a dysraphism, closed dysraphism, but also kind of almost even on the atretic twin spectrum of things. So first, given his hydrocephalus, we chose to shunt him. I appreciated the way that Sir Ron and the folks at PGH tend to shunt everyone with, a lot of the patients get a Keen's point shunt with this belly down, bowel down, reverse T. Positioning. The Keen's point allows just for one single pass, which I appreciated. And there are no programmable shunts because they're just too expensive. And so everybody uses a burr hole type shunt like this. And I like how Saran always puts a little periosteal flap over that so that it prevents like wound erosion, which was nice. So then we flipped the patient and turned our attention towards the posterior lesion. We outlined all of the good skin that we would potentially want to keep to cover the lesion, shaved off the hair. And Saran was able to show us where the normal lipoma and muscle, the normal subcutaneous and lipomatous kind of planes were. And we followed that down. We found more normal fascia out laterally. And so, and kind of the normal posterior elements cranial to the lesion. We resected the extra bone and extra vertebral bodies out over here and found them and then tried to follow that into that fibrous tract that we identified, which I think is this thing. And you might remember from the imaging, there was kind of like almost a second dural sac, which is what we're getting into here. And then we followed that fibrous tract in and opened this focally. And here you can kind of see, I'm sorry, it's blurry, but there's like the two hemichords, I think, here, and here's the fibrous tract. We tried to feel kind of in between the two hemichords for that anterior septum, but we didn't to see if it was tethering at all, but we didn't see it there. So we left it, especially because there's no nerve monitoring available for these cases, and this patient still had ambulatory function. So we closed him up. There's a tradition there on the pay service. The attending will buy takeout for everyone after the case. And then here this patient is a few weeks later in clinic and 1 month post-op now. Saran told me that he's actually taking his first wobbly steps. Our next case is a 2-month-old. He had this lumbosacral mass in the context of club feet, neurogenic bladder, and perforate anus as post-colostomy. And here's this mass here. It's almost like entirely filled with CSF. You see like a dysplastic placoid ending here, but no neural elements coming on. So we call this a myelocystocele. And we had to wait a few weeks actually for that MRI to happen. We didn't want to send this kid home because he lived a 4-hour plane ride away on an island up north. And so we took him to the operating room to fix this lesion. He'd never laid supine in his whole life, so this is anesthesia, getting creative with like a little boat that they put the lesion in order to lay him supine to intubate him. Here's our beautiful team. This was Dr. EJ's case, PGY3, that I was able to assist with, and Dr. Clerkin, our visiting attending from the US at the time. And here's the patient. And so after we prepped the patient and went to scrub our hands, we placed an angiocath needle so that the fluid could slowly egress outwards. And I'm sorry I don't have case pictures, but basically we used a similar approach. We outlined normal skin, cut around it, let the cyst egress, found kind of like an inner layer of dura, found what was like a very dysplastic placoid with dysplastic nerve roots. We detethered that, imbricated it, and recreated the dural sac, and then closed up. It looked like this. He didn't leak at all post-op. His head circumference did increase a little bit, and he was, after some observation, sent home with Dr. EJ's cell phone number in order to do close head circumference monitoring. We do plan, if he has worsening hydrocephalus, to bring him back for an ETV when he's old enough at 3 months, if he can get to there. Finally, our last dysraphism is this 6-year-old female who was born with this lump. She had 3-year history of, she was actually walking, but then she started losing that and had progressive diparesis spasticity. She, on exam, had no volitional motor, but she was withdrawing her left greater than right extremities, and she had spasticity and clonus and a T10 sensory level. We were quite puzzled by what this was. We were asking, is this a syrinx that had fallen out? Is it the cord going out and coming back in? Is it a like a lipomatous lesion? It was a mystery. And looking at the CT here, you see that T6 through 10 are missing, and so we did the case supine. We opened up, got down to normal, which is the T5 here, and then got into that like outer dural sac. And then we found this area, which kind of looked almost like a dorsal lipoma type pathology, and we followed that plane. Then soon we got into this pocket. And inside that pocket, we found this, oh, sorry, I think I was on presenter. Oh, okay. Oh, sorry, that slide didn't change. But anyways, then we found this like kind of like sebaceous keratinaceous stuff with hair, which we were like, oh, this stuff was kind of like a dermoid type thing. Then we put the cord back in there, and it was pretty spacious, and we closed the dura there. So the pathology was consistent with mature teratoma because they were all different tissue types. Post-op exams unchanged, but our goal was to detether her, prevent from getting worse, and maybe down the line to help her spasticity from untethering. Moving on to open dysraphisms, this was a 4-week-old female who still had not yet had her lumbosacral myelo repaired. She was born in an outside hospital. They were told that they didn't have a microscope. That was their excuse. She did have very weak leg movements, no hydrocephalus, and the mom had been cleaning this open lumbosacral lesion every twice a week. And so we took this patient to the operating room to repair her. We used 6-0 and then 5-0 for the placoid and dura, Vicryls for the myofascia, and 4-0 nylons for the skin. We incised into the subarachnoid plane, left a cuff of 1 millimeter of epithelial tissue around the placoid, followed that plane, exposed the placoid, the cauda equina, took off all the epithelium that we could, and even scraped some scarred stuff off the placoid, imbricated it to prevent retethering, and then reconstructed a dural tube with this dura out here, then a myofascial layer, and the skin. And here's another one that I'll breeze through for sake of time, but this patient's actually 7 months old. When he was born at his outside hospital, they were told that they weren't allowed to do, like, they didn't have enough anesthesia time, so they couldn't repair his myelo, but they said, we can shunt your hydrocephalus. So they shunted him. He was complicated by multiple revisions and actually presented us 2 weeks after another shunt and septostomy reimplantation leaking. He was alert and active, bilateral lower paraplegic. And we explained that his shunt, because it was leaking, he had this history of infection. And here's what his ventricles looked like. He had an open fontanelle, so we watched him, didn't have to tap him, gave him antibiotics. And when the CSF came back clean, we chose to bring him to the operating room. You can see at birth, it almost looks more like myeloschisis. There's not like a big sac there. This case was like a lot harder to find normal planes. Everything was really scarred in. This is a picture we took after at the very end. And this patient leaked once, but his head circumference actually has been stable. His shunt incision did not leak. And so I was surprised, discharged him home shunt free. And I was told by some of the residents that they have seen this before, that like even in hydrocephalus myelo patients, they with loculated, like post-infectious, like with infected hydrocephalus, sometimes they'll kind of graduate from shunt dependency for whatever reason. So yeah, there was a lot more dysraphism that I saw. This is the NICU. Here's one of the open lesions. Here's there were like 7 babies that we shunted while I was there. This patient is was waiting there in that long queue, and unfortunately was really trying to look at us, but just keeps sunsetting from his hydrocephalus. This is another modified Keen's point done by Dr. Bonko, PGY-5 after talking to the chief, and plenty more dysraphisms that I was part of and also saw in clinic. And also many congenital diseases like this encephalocele in the NICU who ended up progressing to hospice care, as well as this baby. So then we'll move on to tumors. I was able to participate in 11 tumors. This first is a 19-year-old. She had tunnel vision, diplopia, papilledema. She only had these visual fields left, and she was found to have this large left parietal occipital lesion with a mural, conscious-enhancing mural nodule and a large cystic space. And so we took her to the operating room, and these are actually like printed out physical images. They're not DICOMs, and so we planned our incision by measuring off of this piece of film, and did a large cranie because it came very superficial, and we wanted to be able to encompass all of it. We did a trapdoor incision. We resected the nodule. The cyst we couldn't see very much, but our goal wasn't necessarily to resect it because we suspected pilocytic astrocytoma. One thing I learned from this case, so they do use ultrasound there, and as here in my natural habitat at Brown, we always use ultrasound, but the ultrasound at the time was broken. And so we planned our, incision and everything off of craniometrics. But when we, had our big dural exposure, there were kind of like 2 bulges. And Saran said to myself and Dr. EJ, which bulge is the tumor? Where do you want to open the dura? Like, try to open the dura so the brain doesn't mushroom out at you and it's tumor coming out at you. And so we kind of poked the 2 bulges and decided one of them was the tumor. But we got it wrong. The bulge that we opened over was actually the occipital lobe, and it started coming out at us. So that was a humbling experience because, just learned to be more adaptable and not as maybe dependent on, learning to do things in a different way without my normal adjuncts, that I'm used to here. But thankfully, we quickly were able to get into that cystic space, which relaxed the brain a lot, and the rest of the case went really well. This is the patient a month later in clinic. She'll get an MRI next month, and we do think it's a JPA. That's her incision healing nicely. Then we have a 4-year-old intraventricular tumor patient who presented with progressive blindness over several months. He was bumping into furniture and had an ambulatory decline, had significant optic atrophy, and he had this very large multilobulated heterogeneous supracellular lesion. And so we suspected optic pathway glioma versus germinoma versus craniopharyngioma. He was started on mannitol until we could find him in operating room. And then we went to the OR. We used this was our operative plan for an endoscopic approach: septostomy, biopsy, and then shunt. This case, I remember one challenging thing was that it was very murky in there, maybe I guess from the lesion. And so we had to their scope had to get really close to the membranes to fenestrate anything. But we did it. And he did well. Post-operatively, his pupils pre-op were non-reactive. He only had light perception, but post-operatively, they became reactive again, although his vision unfortunately was unchanged. Pathology 1 month later, unfortunately, is still pending, but we do think we're hoping it's a low-grade glioma, optic pathway glioma, and we'll put him on an adjuvant protocol for that if that is the case. This is not the same patient, but it's a piece of artwork I found in Sir Ron's office. It was a painting drawn by another child's family with a supracellular lesion, which I think is beautiful, and a kind of another example of just Filipino gratitude and hospitality, which I was able to witness. So then we have a few posterior fossil lesions. This is a 3-month-old with dysmetria, generalized weakness and tension tremor. As you can see, massive obstructed hydrocephalus. A lot of patients came in with these, or even at PGH, we would get a lot of MRIs not as available as I'm used to here. And so there are a lot of contrast enhanced CTs, which I really wasn't used to, but kind of became a little bit more familiar reading. Because of the long operative queue, we had to shunt him first. Ideally, we talked about that we would, ideally we'd bring him to the operating room as soon as we could and do a peri-op EVD, but the queue was long, as you had seen, and there's a very high risk of infection in the very tropical climate there. Given the high risk of shunt dependency, we decided to actually shunt him. And then about a week later, we were able to finally take him to the OR. And so you see this lesion comes very close to the vermian surface. And so we did basically used that plane and did a mostly vermian approach using the natural incision that the tumor gave us. But first we did inspect this televelar area to look for if there are any feeders to devascularize. We didn't find any, but we were able to egress some CSF for brain relaxation in the basolateral cisterns. We used, here's the case. The most difficult part I recall was we discussed the draining veins here up at the apex, which drain into the deep veins. And so our plan, when what Sir Ron did was we debulked all of this stuff down below so that we had a lot of room once we got up there, so that we would be able to handle whatever it showed us. It wasn't too bad, honestly, the bleeding up here. So, but we were prepared if it were, and also learned the pearl from Sir Ron that the most common place for residual and a tumor like this is actually up and behind your scope. But thankfully, we got what we believe to be a gross total resection here in the patient. And although he has these enlarged subarachnoid spaces, we didn't see any clinical signs of over drainage. He did have some vermian signs postoperatively, but that improved over a few days. And here he is coming back to the hospital for a spinal MRI 2 weeks later, which was clean, no drop mets, and he's ambulating here. We'll see if he'll get radiation or not. Here's another posterior fossa tumor in a 13-year-old, also with ambulatory fine generalized weakness. He had a wide-based magnetic gate, dysmetria. He wasn't as decompensated, and the queue was shorter at that time, so we did not choose to shunt this patient first. And you see this large lobulated heterogeneously enhancing mass compressing the medulla of the fourth ventricle, obstructive hydrocephalus. And so for this patient, we were able to bring him to the operating room within a few days. We decided to try and keep him shunt free and do an endoscopic third ventriculostomy. And here's his beautiful anatomy. This is done by the chief Diana and PGY2 Dr. Banco. And the tumor, we did kind of a combined cerebellar and transvermian resection, and the lesion was, the tumor was really tough, unfortunately, and there was no CUSA. And so I was just included this video to show this PGH maneuver of using micro scissors, which are not always sharp, to try and cut out just make the tumor more suckable when it is not. So we did that for a very long time. Finally, we saw some OVEX. And here is his post-op imaging. He did have some Vermean signs and a cranial nerve 7 palsy, but was still speaking and sitting in a supported fashion. I think it shows, no, it's skipping it, like a near total resection here. Unfortunately, this patient 1 month later came back with pseudomeningocele and ventriculitis. And so, although we tried, we were not able to keep him shunt free with the ETV, and that failed. So we had to place an EVD, treat his ventriculitis, and then we have since actually placed a shunt. He's, I'm told, more talkative now. He has better truncal control. My last tumor case is an 18-year-old female with progressive swallowing difficulty who has this non-enhancing large lesion expanding the cervical medullary junction here. She was left side just mildly weak and had a little bit of swallowing difficulty. And this was Sir Gap's case on the PACE service that I participated in with Dr. EJ. Here we are. We did a suboccipital craniectomy, and this, when we opened the dura, we saw the tumor just coming out at us, expanding the medulla here. We didn't have any, there's neuromonitoring at PGH, but only for certain applications like cranial nerve 7, for example. So we did not have neuromonitoring in this case. And here, Sir Gap, when we were here, he asked me, so Belinda, where do you want to open the corticectomy, and got to the tumor? And I was bewildered because I couldn't figure out where the median sulcus was. It was quite distorted, and he kind of pointed to one spot and said, I think this is where it comes out. And we made a corticectomy. This is the only type of monitoring we use. This was anesthesia, holding the ambu bag and palpating to make sure the patient was still initiating spontaneous breaths. Our pre-case huddle, we decided that we would only be able to debulk the lesion because of it being in the medulla. And looking at this, we decided that ahead of time that we would only go up to kind of where this lower cranial nerve complex was. And if the patient at any point before that stopped spontaneously breathing, we would then also stop with our extended resection. So here we did find that lower cranial nerve complex and around this, and then the lesion itself, sometimes it had a good plane, many times it did not. Here, it kind of did. And this is, and then she did at one point kind of start to lose spontaneous respirations. And so we promptly stopped, and she got them back again. And this is the resection cavity. And so, I had really held my breath, but immediately post-op, she was extubated and following command speaking. Her left side was weak. But a week post-op, here she is with only a left upper extremity drift and starting to ambulate with a walker. This is the day that she asked me, are you 100% Phillippine? And I said, no, I'm 0%. This is compatible with a low-grade glioma as well. Maybe I'll skip this for the sake of time, but this was actually a challenging case. Anyone who wants to learn more can talk to me, but it's a large central what we suspect to be a large central neurocytoma that we did right frontal transcortical intraventricular. It was very bloody, it took all day. In this case, the patient did very well after surgery in terms of like being extubated and following commands, but hemiplegic, and then kind of declined. And then for a combination of maybe like EVD issues and maybe some venous injury, perhaps. Sorry, this imaging is not loading, but he declined. We had to take him back to the OR. We had to revise his EVD. It was found when they intubated him to have been pulled out, so we had to replace it, and then it was working. It drained a lot, and then 4 hours later that day he was fixed dilated GCS3T coding. We coded him. The rule on the charity service is to only code every patient for 20 minutes, and unfortunately we lost him. And I remember that mother was just beside herself. And this kind of segues to some quality improvement that I was able to participate in there. It was a difficult case. That was a difficult case for me. This is because of some of it was like, after like COVID, a lot of like nursing and ICUs switched around. And so the neurosurgery service itself doesn't, they used to have their own ICU, now they only have 2 ICU beds. So this patient, as well as several other patients with EVDs and ventilators, are actually on the floor with only floor level of nursing care. This is actually like, you know, thankfully we're able to use an actual EVD, but this was like their older EVD setup, which is a pediatric feeding tube or Foley placed in the ventricle connected to a sterile PRBC transfer bag. They've been working on this a lot, and we're able to secure, there's a lot of paperwork the residents have to do, but they're able to get this $200 BMI Medical Becker EVD with foundation support. We were able to attach levels to all of them. I'm helping to kind of make like a training video for nursing. But you know, we did often see kind of some dysfunction and problems with people like not really being trained to use EVDs. And as you can see, this very overdrained massive hydrocephalus infant over there. But we attach flow sheets, we attach levels. We're working on the video. We have the signage in both languages to say when it's clamped and unclamped. And as I mentioned, a lot of the bedside watchers, the moms and et cetera, help with the flow sheets. This is that mom who was texting me, recording in the flow sheet. Then we'll move on to our section vascular. So to understand vascular, we have to understand that one coil there equals 1,000 days wages for the average citizen in Manila. And so, you know, they clip almost everything. This was a right A45 junction saccular aneurysm off the pericallosal with some distal distal A5 branches also coming off of it. I did this with Sir Gap on the pacer. It was unruptured. She was asymptomatic. Here we are, we went interhemispheric. Here we are dissecting. Another maneuver, if your micro scissors don't cut, you can take a 27 gauge tuberculin syringe. Apparently very resourceful and creative. Here we are exposing the dome of the aneurysm there in the interhemispheric space. And first we tried to place this single permanent clip in it with that temporary one on there, but Doppler revealed that we were also clamping off the distal A5, this should say. And so we actually had to take that off, and this was our final kind of 2-clip construct. And because of the other vessels that were coming out, there was some kind of neck that was left unaddressed. And so we did also put a little bit of cottonoid for like kind of like a wrapping for good measure. Right after that case, work never stops. The chief came in and staffed another operative place for the next ruptured aneurysm clipping. My last vascular case is this case. It's a 28-year-old who had been walking around like this for a year. This was his common carotid injection here, and you can see the ICA territory is not filling. It fills directly into the cavernous space, and so cavernous sinus showing us a direct carotid cavernous fistula. And 1 year, we didn't have a bed for him for a whole year, and so he came back to clinic, and he's now having some steel symptoms, left arm numbness and weakness. And he walked around wearing a piece of notebook paper taped to glasses to hide this right eye from the world that you can see is very proptotic and conjunctivally injected. Just a closer view that the right ICA territory is supplied by the contralateral anterior circulation and also the posterior circulation there. And so 1 year later, we took him back for another angio and talked about operative approaches. This was a dynaspin just showing the lesion and the very dilated draining superior orbital vein and into the scalp veins. Here's his angio 1 year later, not super changed, but some of the IC territory does fill after that. But there were no feeders from the ECA, so this is still a direct fistula. And so we actually talked about this case a lot, but it was time we decided for this thing called the pop and clamp. So this 28-year-old with the Barrett type A fistula, we planned for left ICA sacrifice. And how are we going to do this? We chose to use this thing called a pop and clamp, which is basically a sequential open approach multi-day test ligation of the ICA. And so you place this clamp, you expose the ICA, you place this clamp. This is the clamp open, this is the clamp closed. Every day you can tighten it by 1 millimeter on the floor and make sure the patient doesn't have any worsening of symptoms. And if that's the case, then you can take him back. So here's the application of the pop and clamp. He did well on the floor, sequentially tightening it. So we decided to ligate his ICA. So here's the ICA ligated and the right pop and clamp removed. 1 month later, I'm told he's been seen in clinic. His eye is getting better. For for the sake of time, I'll kind of skip through these things. They do get trauma. I just wanted to show we get a lot of trauma to Rhode Island Hospital. They also have unhelmeted motorcycle crashes. This is a GCS 12T with an open depressed skull fracture and involving like the orbital roof, which we took to, and some coup contra coup contusions there, which we took to the operating room, which I participated in with PGY-5 Cyron, Dr. Cyron. So here's the fracture, and then we took all that bone off, debrided it, washed it out really well, cranialized the frontal sinus, used periosteum, stuffed it in there. There are no plating systems. They're too expensive, and so even like a simple flap, you sew it in with silk sutures. And so this patient, I took a card from Dr. Smokos, Dr. Wu's book, and did a split calvarial grafting, split the calvarium in half, and kind of made this little mosaic and tied it into place for the patient. That's our beautiful operating room team, and post-operatively he did well. He never leaked, and he was extubated and has since been discharged from the hospital. I want to leave some time at the end. So, oh, this is a jiggly saw. Let's see. I did this. This was a bunch of pus that we took out of this big abscess, but you know, we drained it, but we actually should have done this. He worsened, so we actually really should have done an open cranie. There was a lot of tuberculosis there. This is a clival lesion, a 13-year-old with posterior occipital pain, swallowing difficulties. You can see here, there's like atlas assimilation, basilar invagination 13 millimeters above the basionopistion line. He was actually neurointact, surprisingly. This is what he looks like. And there was a lot of debate. I texted Dr. New, our director of deformity here, and we talked about should we traction him, halo him, et cetera. We actually decided, since he actually was autofused at a few different points, he was placed in he was just kept in his collar, and he's actually still doing well. This was TB devastating another patient, which was really sad. This is what it looks like to have disseminated TB with hydrocephalus, TB vasculitis, bleeds. She also has POTS, she's plegic. And her hydrocephalus was complicated by multi-drug resistant A-Balmani ventriculitis. And so these TB cases just really highlight a lot of the ethical and moral kind of like tumult within my soul that I experienced. A lot of these preventable pathologies were hard for me to see, given that, you know, understanding that they're really attributable to, you know, some preventative type things. And I felt like every day, you know, interacting with these patients and their families in the charity service, we were constantly just looking at the face of poverty, at the face of inequity. As Sir Ron writes in his book, it's not the child's fault they were born Filipino and poor at the same time, that their mother didn't have folic acid, that TB is not yet eliminated. And had they been born elsewhere, maybe things could have been different. Not to mention the neurosurgeons maybe wouldn't be as burdened with all of these preventable diseases, and maybe they could focus instead on like more preventable illnesses. Imagine a service, you know, not running after any open dysraphism or tuberculosis related hydrocephalus. And, you know, it was difficult because putting my public health hat on, you know, I was like, what am I doing? Like, where can we have a bigger impact? Should we, you know, be spending our time training neurosurgeons to kind of contend with disease, or should we go and fight these complex public health battles that are necessary to reduce them? But, you know, let's not get too carried away. Take a step back. We actually have our own preventable diseases plaguing children in the US, like firearms, which have exceeded motor vehicle crashes and devastate some of our patients that we see here. Our own inequities, you know, based on race and class therein. And glaring disparities just in healthcare outcomes. This is a classic Aid America's paper. You know, our solutions are just as complex. You might say, why don't you just eliminate this? But everyone will remember this Twitter battle in which doctors were told to stay in their lane, you know, when it comes to gun violence. And we're really not getting it right either. You know, we spend far more on healthcare for not as good outcomes, which our department has kind of talked about in the past. And so, you know, in these kinds of situations, when you're in another place and you're troubled, you know, helps, I think, to take a step back to know that it's a different place, life and death, quality of life, complications, morbidity, it's a very different context. But I was inspired by a lot of the work that folks are doing there, not only to, you know, help these patients and impact these individual lives, but also kind of on a systemic scale. Sir Gap had told me I never wanted to be director. My entire world used to only exist within a 10-centimeter radius at 3.5 times magnification. And if anything got in my way, I didn't want anything to do with it. But now I realize from the director's seat that all these problems can only be solved outside of the operating room. And Dr. Barkley, when she was there, said, the OR is the easiest part a lot of the times when you're in a very different space. It's everything around it that's incredibly difficult. And also another, I guess, comfort is that, some days you can't save them all, but you can really help that one patient and that one family, in front of you. And so there are Filipino neurosurgeons going before Congress. Sir Gap goes to discuss budget. And there are people appealing for folic acid fortification being mandatory. This is a clinical trial that was funded because Sir Gap went before Congress and asked for budget to fund this HIFU clinical trial for an endemic Parkinson's. This was a HIFU conference that I attended when I was there, during which we watched a live stream of surgery happening down the hall. And yeah, that's about it. I did want to, this is another talk in and of itself I can talk about another time, but I was involved in some research there. We talk about the shortage of neurosurgeons. So, and, there's a lot in Manila, but not a lot elsewhere. And so, what do those patients do? Can we have a platform in which, neurosurgeons at PGH maybe can virtually telementor surgeons elsewhere through a surgery? And so we use this technology to have a cadaver lab. And Dr. Aldana from Florida telementored with a live feed of the scope, the residents here going through a selective dorsal rhizotomy. And so, yeah, thank you so much, everyone, for coming. We have about 10 minutes for questions and discussion. Yeah, if anyone feels compelled, you can make a gift to also the resident fund. There's a QR code, or you can Venmo me and I can handle it. Or also the Sanjeev Bhatia Fund, which I'm thankful for, to fund future people like me and go and rotate. So thanks, everyone, and take questions. We also have, if you have like specific questions for people from PGH, they're also on the call.
Yes, I just comment about the direct fistula. What you call top implant, a clamp, we call a silver circle. Yeah, SELVER. And I've used them several times. The problem and the problem I had with them was that the clot can form as you're clamping it down at the bedside. We used to have to keep the patient heparinized because of that. One way you may want to think in the future of handling that is just doing an awake carotid exposure and clamping the internal carotid with the patient awake. So you'll know within 20 minutes whether you can, and that would avoid the use of a clamp. If the patient didn't tolerate it, you could always try a clamp. I get the concept that as you're dialing it down, maybe you'll promote collateralization over a period of time. But since you have to expose the carotid anyway, do it under local anesthesia, clamp it, and see how the patient does. Because if they tolerate it, you can avoid the clamp.
Cool. They do a lot of awake surgery there. So. Yeah.
Belinda, this is fantastic. Thank you.
Thank you, Pasha.
Question, but also, like I told you, how impressed I was about like the dysraphism, things that we never see, and what expertise they have. That's really amazing. I have a question. You said like for adjuvant therapy, given that there's so limited resource, like if there's brain tumor surgery, is there also a lot of delay to get like maybe chemotherapy? How's that going? Comment on that.
Yeah, the folks on Zoom, can you hear the question? Dr. Klinga was asking what the delays or queues are for adjuvant therapy, like chemotherapy and radiation.
Hello, everyone. Just to give you an idea, so our patients, for example, when they're service patients, so for example, we've resected their medulloblastoma. So it's a lot has changed now because we are now able, for example, to give them chemotherapy or radiation therapy at a minimal cost. However, the problem sets in, for example, if they end up staying in the hospital for much longer than expected. So, for example, if they develop pneumonia or ventriculitis, because what happens is that they exhaust the PhilHealth or National Health Insurance allocation because patients are only allotted a certain number of days per year. So for example, if they end up staying 4 weeks in the hospital, then it takes away the funding for their radiation therapy. So that becomes a problem for them. So then they would have to pay out of pocket for the radiation therapy. And then the other thing we've done in the last 3 years is that we've started to have a patient navigator, meaning to say there's usually a nurse or a coordinator who reminds them that they need to go see, for example, follow up for their chemotherapy, or they need to get radiation therapy within a month after surgery. So when I was a resident, we would get to operate on these patients. So for example, we would be able to take out the entire tumor, but then they wouldn't be able to undergo radiation therapy. So they would come back 6 months later with terrible recurrences. Since we've had a patient care navigator, it has improved. Our survival outcomes have improved.
If I may add, Belinda, for adult patients, temozolomide is now standard of care, but unfortunately, we have a problem having it approved by our government as part of the we have this policy that only medications in the national formulary, as determined by the Department of Health, can be paid for by the government. And we've been trying to include temozolomide for the last maybe 10 years, and it couldn't get approved. Just recently, we got denied again. So that's a problem with our adult patients needing adjuvant chemotherapy. So radiotherapy is more or less taken care of now, but the adjuvant with temozolomide is the one that we have to make do with a lot of donations and maybe out of pocket from patients. There's a very disheartening research paper written by one of our residents in maybe 10 years ago, Ronnie, or 12,
Yes.
15 years ago, that the biggest predictor of a poor outcome in a pediatric medulloblastoma patient is whether the patient is a charity or a private patient. So the private patients, of course, understandably fared better, much better than the charity ones. So since then, we have started equalizing the opportunities for both private and charity medulloblastoma patients in terms of chemotherapy and radiotherapy. I think we have the same target time frame for the treatment of this.
So I also want to add, for example, for low-grade gliomas like pilocytic astrocytomas, we are only able to enable carboplatin, vincristine. But if they fail, we don't have targeted therapies. So if they're allergic, for example, to carboplatin, vincristine, they may get vinblastine. But if the tumor still doesn't respond to that, that's the end of the line.
I had a more a comment than a question, and I just wanted to take a step back and acknowledge, you know, what Belinda just did and what she experienced in the Philippine General Hospital. This is the first. Belinda was the first awardee of the Sanjeev Bhatia Fellowship. And the Philippine General Hospital was the first site to host a fellow, and it took a lot of work in the background, and like to acknowledge Dr. Legaspi and Dr. Baticulon and the AASC and speed section leadership for making this happen. And I just want to say that you know, you folks at Brown should be proud of Belinda and how she did such a great job at the Philippine General Hospital, and you know, as you all saw in the audience, the amount of heroic work that gets done in the Philippine General Hospital every day with neurosurgery, I think you know, there should be a great thanks to the group, and hopefully this will be the start of further collaboration with the hospital, and you know, we'll continue with the work that Belinda started. So, you know, thank you everybody. I just wanted to put that out there and recognize you all.
Thank you, Dr. Aldana.
Linda, if I may also add another comment, I was really intrigued by what Belinda described as a non-teaching service of the hospital. Because our problem with our hospital is it's resident and fellow intensive, and as in terms of service, and we're now starting to make the service consultant intensive as well. And I heard about that concept of a non-teaching part of the hospital, which I would like to one day discuss with Brown and see if we could make it work in the Philippine General Hospital, because we're starting a hospitalist program for internal medicine and pediatrics. And maybe we'll expand it to other services as well, where the patients are taken care of exclusively by attendings rather than trainees. So just one thing I learned from Belinda's comments about the system in Brown also.
And I just want to say, being her mentor for 5-6 weeks here in Philippine General Hospital, she really set the bar so high. So I think all the future international fellows in pediatric neurosurgery will have a hard time trying to fill her shoes. But the beauty of having someone like Belinda come over to the Philippine General Hospital is that, it's a two-way street. She learns from us, we learn from her, our residents learn from her, and I think really just we had a discussion among the consultants after she left for feedback, and we all agreed that she did really, really well. Not just from knowledge and skills, but personally for me, it's really the way she took care of our patients, and how she had genuine care for them. And she really knew every patient, even their watchers. She ate our meals. She went to our canteen. She loved sinigang, and if she saw her running with the residents, you would not be able to identify her as the international radiator. So thank you for sharing her with us. So we hope this will be a continuing partnership, and I'm sure because her heart is in the right place, she will be a wonderful pediatric neurosurgeon.
Well, thank you for sharing that, because we feel the same way about Belinda, so it's no surprise to us at all. A comment about the non-teaching services, at least here in the United States, that's only going to get more prevalent because the residents are beginning to unionize. And as part of that unionization, we know there are going to be further caps on the amount of patients that an individual resident can care for. So that model has been set up here, but I think it's going to have to be significantly expanded at most places.
But we'd be happy, I think, to connect you, Sir Gap, with the head of IMIS or whoever it is,
Yes.
if you'd want to talk to them, the head of the non-teaching service.
Yes, we'll be very interested in that. Thank you very much.
And I think it would help the residents a lot. I think this is hand. Maybe time for one more.
Really amazing talk. I had a question about what the practice of the consultant surgeons and residents look like, because they take care of so many different pathologies. Do they mostly end up being general neurosurgeons because of the need, or is there room for specialization and pursuing different interests in PGH and what can be done?
If you could all hear the question, he's wondering what people's careers look like when they go into practice. At least what I saw, like at PGH, 68 out of the 174 neurosurgeons in the Philippines are there. And so people are subspecialized, although they all practice some amount of general neurosurgery. But I did get to connect with a graduate, Dr. Miriam Hong, who actually went back to her province, where neurosurgeons are really needed. And so she's definitely a generalist because she's the only one there. And she is pediatric trained, which is really helpful because a lot of the burn disease is pediatric. But anyone else from the Philippines can comment.
So Belinda, so in our workforce paper, around 40% have subspecialty training. Around 40% have subspecialty training, but the average neurosurgeon in the Philippines. So we surveyed the neurosurgeons in the Philippines. The average neurosurgeon does about 20% pediatrics. So 1 out of 5 patients will be pediatrics. We do far fewer spine cases, so 10%. So median percentage of spine cases is just 10%. It's mostly cranial. Half of the cases are emergency cases. Half of the case, and about 30% will be public patients. So the average neurosurgeon that's the average neurosurgeon for you. And as Belinda showed earlier, 40% of neurosurgeons are in the national capital region, and 60% are in the provinces. Previously, it was the reverse. Previously, 60% were in the national capital region, but we're slowly seeing a shift towards more neurosurgeons going to the provinces, doing much general neurosurgery work.
If I may add also, I think the general pattern, as you were asking of practice, is after we graduate, we apply to as many private hospitals as we can, and we choose a government hospital where we want to work with. So that balances our activities a bit. So we have service and training in one aspect, and we have our source of income in another hospital. It was not uncommon to see a neurosurgeon go to 7 or 8 hospitals at the start of their practice. And just like me, I mean, I started with 8 hospitals and now down to 2. One of the biggest private hospitals and the biggest government hospital. So generally, that's how the trend of practice goes. But more recently, we're now emphasizing on subspecialization. And I think Ronnie is probably one of the first pediatric neurosurgeons who can now start weaning away from general cases as time passes, because our first pediatric neurosurgeon, trained by Harold Hoffman, had to do general neurosurgery eventually, because he wasn't going to survive with pediatric neurosurgery at that time in the 1980s. So.
All right, well, thanks everyone, and hope to see folks here one day as well. Maybe in July we'll have Sir Gap when he comes to Boston. Can't thank everyone enough. Have a great day in the OR or
Thank you.
in your beds.
Thank you, Belinda.
Bye-bye.
Bye.
Bye-bye. We'll see you soon.
See you
Bye-bye.
soon.
That was lovely.
Thank you.
Bye.
You really rehabbed your vocal cords a lot.